Good afternoon and welcome to another episode of Fertility Talk. Today we are talking to Dr. Sulaiman Heylen, and he is a fertility specialist at Cape Fertility. So we've had Dr. Heylen on quite a few times, but thank you very much, Dr. Heylen, for joining us today.
Thank you, Leanne, for inviting me again. It's always a pleasure to help fertility solutions and a pleasure to talk to the ladies and gentlemen out there.
Thank you, Doctor. So today we're going to talk about why my IVF failed. And I'm sure, like Doctor, we just spoke, and you said that this is what happens when it does fail. Women come in and sit in front of you, and this is what they ask, the common question that is asked. So we're going to go into our first question. It says, what are the most common reasons for a failed IVF cycle, and how can they be identified?
So if you look at IVF, and at any IVF, you need three things. You need a healthy woman, you need a healthy uterus, and you need a healthy embryo. And the healthy embryo comes from the healthy egg and the healthy sperm. Now we know, and there is no doubt about it, the main driving force for a successful IVF is the embryo. It's not the lady, it's not the uterus. It does play a factor, obviously. Yeah? I didn't say it's not important, but it's very important to understand if you do IVF, it's the embryo, or the embryo that makes if you're going to be successful, yes or no. Now, how do we know that? We know that because egg quality and embryo quality is related to female age. If you look at success rate for IVF, then we know that for young women, the success rate is very good, up to 50% per try. And now I speak about the transferring of one embryo. Huh? Because these days we transfer one embryo, we don't transfer two embryos anymore. That's a bit old-fashioned. So we transfer one embryo, and for young women, the success rate is up to 50% per embryo transfer. And it decreases slowly until the age of 35. And after the age of 35, it goes down with 5% per year. So 36, 37, 38. At the age of 40, it's about 25%. At the age of 45, it's close to 0%.
Okay.
So basically, that is the story of IVF and the story with success rate, which is related to eggs.
Okay. Thank you, Doctor. Do you still
So,
continue? Sorry.
yes. So, yes, I can continue with this. Yes. Yeah. So, yes. So, now, if somebody comes to me and they have a failed IVF, say, okay, they've been to another fertility clinic and say, my IVF didn't work, and they transferred an embryo and didn't work. Then my first question is, how old are you? So if a woman does IVF and she's 42 and the IVF didn't work, then we know that at the age of 42, you got probably a 15% chance of success. There's 85% that it didn't work. Huh?
Yeah.
So it's nothing abnormal. It would have been actually abnormal that it did work at the age of 42. So it's not likely that for a first IVF attempt at the age of 42, it is successful. Now, if you come to me and you're 35 and you have a failed IVF, let's say you did IVF and it didn't work, then it's like if you toss a coin. Huh? If you take a coin and you toss a coin, you've got 50% chance that you will win or lose. If you do IVF, it's the same thing. It's like you toss a coin. See if you got a 50% chance of success, which is for a single embryo transfer, more or less the best what we can get. And I'll come back to that later, but anyway. So if you got a 50% chance of success, then it's 50% chance that it doesn't work. So it's also not abnormal. Huh? So if you toss a coin and you lose, then you don't say, why did I lose? You just say, okay, yeah, it's because I lost. Huh? And we as doctors, we are sometimes very stupid, huh? Because we do IVF and it doesn't work. And we do IVF and it doesn't work. And maybe we do it 3 times and it doesn't work. And then we call it recurrent implantation failure. That's a medical diagnosis. Say if you've done 3 failed embryo transfers. And we say there is a recurrent implantation failure, there's a medical diagnosis. So it's like if you toss a coin and you lose 3 times and you pick up the coin and you're going to examine the coin, say what's wrong with the coin. That's stupid, huh? Because there's nothing wrong with the coin.
Yeah.
So this is my major message that I have today. In the majority of the cases, the recurrent failure of IVF is because of the embryo. There's nothing else wrong. It's in the majority of the cases like that. So if we'd like to optimize the outcome of IVF, we must make sure that we have got an optimal embryo. And the other things are also important. We must obviously look at a healthy lady and a healthy uterus. That's also very, very, very important. But then over the years, doctors have developed tests for recurrent implantation failure that very often from a biological point of view and from a statistical point of view do not make sense, like natural killer cell testing. That's the big one. It's been around for 30 years and it's been shown all over and over that it doesn't make sense to do it and the treatment of natural killer cells doesn't help. The other one is ERA testing. There's another one, the endometrial receptivity testing. The multiple studies, prospective randomized studies. That means you do the test on certain women, you don't do the test on certain women, you compare pregnancy rates. It's the same. Some studies even say it's less if you do the ERA testing. And that's the thing with recurrent implantation failure with IVF. Say if you do IVF and it doesn't work, the next time that you do it, in the majority of the cases, your success rate is exactly the same. So if you change something, then you say, okay, it's because of the change that I did that you're pregnant, but it's not. It's just because you're lucky the next time.
Okay.
So if you do IVF, and now I would like to go to a study that's been published last year, a huge study, more than 100,000 patients.
Okay.
And they transferred one genetically tested embryo, and what we call an euploid embryo. So if that's the best that we can get, a genetically tested embryo, a healthy embryo. Now we know it's genetically tested. If you transfer a genetically tested embryo in the uterus, it's got a live birth rate of just over 50%. It's a little bit better than 50% once it's genetically tested. So I will say the patient's about 50-50, okay? Now, if it doesn't work and you do it again, what is your success rate? 50%. If you do it again the third time, what is your success rate? 50%. If you do it the fourth time, what is your success rate? 50%. They did it up to 5 cycles. What is the success rate? 50%. And they've shown that after 5 cycles, the total pregnancy rate after 1, 2, 3, 4, 5 was 98%. There's nearly everybody pregnant, okay? If you transfer 5 times after each other a genetically tested embryo. And out of that study, they said recurrent implantation failure doesn't exist. That's basically what the conclusion of the study was. Doesn't exist. Okay. Or, I mean, I'm exaggerating a little bit. I like to exaggerate. I'm sorry for that, Leanne. Okay. But actually, that recurrent implantation failure is very rare. And they said you only should test for recurrent implantation failure if you've done 5 times an embryo transfer of a genetically tested embryo. Yeah, I haven't seen many patients like that who come to see me are not pregnant. It's something that I even don't see every year.
Wow. Wow.
Yeah,
Thank you.
yeah. So now you ask me what tests we should do.
Yeah.
That's another thing, huh? Because I said we have to have a healthy woman and we have to have a healthy uterus. So what do we know? And what is no doubt about it? That a woman who's not healthy has got a reduced chance of conceiving. Now, what I'm speaking with, and now what I'm going to say is extremely unsexy. It's nothing sexy. It's very, very boring. Huh?
Mm.
But women that smoke, women that drink, women that are unfit, women that are overweight, we know that they have a reduced chance of conceiving with IVF.
Mm.
And that has something to do with the uterus and the implantation, but there's also something to do with the egg because it has got an effect on egg quality also. So it's a double effect. So if women like to have a better chance of having a baby, then the major focus should be on their lifestyle.
Mm.
Stop smoking, stop drinking, eat healthy, do exercise. If you're overweight, try to lose weight. So there is now something that we call these days Ozempic babies, huh? That's the
Mm.
terminology that you've heard about, I guess. Okay.
Yeah.
Yeah. So what's an Ozempic baby? So Ozempic and other GLPT-1 agonists, I mean, that's the name of the drugs, but let's just call it Ozempic to make it easy. These type of drugs have been becoming popular in the last few years for weight loss.
Mm.
So a lot of doctors have prescribed Ozempic for women, for young women, to try to lose weight. And what I've seen that a lot of them lost weight indeed because it works. And
Yeah.
it's one of the drugs that, it's that type of drugs is for the first time ever, we've got something that can really help to lose weight.
Yeah.
Women lose weight, they lose 10% of their body fat. And what happens? Pregnant, no IVF,
Mm.
spontaneously pregnant at home. So that's the Ozempic baby, huh?
Yeah.
So we know that women that are overweight have got a reduced chance of conceiving, and when they lose weight, they've got a better chance of conceiving. Associated with things like polycystic ovarian syndrome, I mean, we know all about that, that
Mm.
the polycystic ovarian syndrome and the weight gain, they are associated.
Yeah.
And when women lose weight with polycystic ovarian syndrome, they're starting to ovulate and they're starting to conceive. So the best thing, if you would like to try to conceive, is to focus on the healthy woman part, which is important for trying to conceive spontaneously, but also for trying to conceive with IVF. That's always one of my talks when they're coming here and we identify underlying factors. And there are other ones. The two most common ones are hypertension and diabetes. So we must work on these also. So women come to me and they've got hypertension, diabetes. We must focus on these diseases. So over the last few years, I've become a doctor more and more involved in treatment of metabolic disorders and healthy lifestyles, okay? And focus on diabetes and hypertension and weight loss and all these things and healthy lifestyle and exercise and becoming like a sports coach. Because these things are really, really very important for health, and a healthy woman will have a much better chance of conceiving. And the focus has come completely now to that, to try to have a healthy woman than to focus on all these stupid tests that we used to do in the past.
Yeah.
Yeah.
Wow. Thank you very much, doctor. I actually feel that you've covered everything. So now I do understand what you're saying. You've covered everything in that one question. So thank
That's
you
what
very
I say.
much.
Yeah, you've got only one question with all your questions.
Yeah, yeah. But thank you very
Now,
much, doctor.
now, the other thing is obviously we spoke about a healthy uterus.
Yeah.
Yeah, that's also important. Because obviously there can be abnormalities of the uterus. And I'm speaking about the uterus and not about the ovaries or the fallopian tubes.
Mm.
So endometriosis is outside of the uterus. Hmm?
Mm.
Polycystic ovarian syndrome, these women are good for IVF. They make lots of eggs.
Mm.
Blocked fallopian tubes, we bypass the fallopian tubes. That's fine. We speak about the uterus. So an abnormality of the uterus. So it can be fibroids of the uterus, or adenomyosis of the uterus, or polyps of the uterus, or chronic endometritis of the lining of the uterus. So we must try to optimize the uterine factor also. And in the past, we had ultrasound machines where we scanned and we could see the uterus and the ovaries, and that's it. But now we have much better ultrasound machines. So every time that we get a new ultrasound machine, we make new diagnoses because we can see so much better. That's amazing how much the technology has
Yeah.
advanced in the last, the vaginal ultrasound came out when I was a medical student, and you can see from my gray hair that I'm not so young anymore. I'm still young, but anyway. So the technology has evolved a lot. So you can, it's like a phone, a cell phone. I mean, 20 years
Mm.
ago compared to now, it's the same thing. We can see so much more, it's so much better. So now we speak also about detailed ultrasound and not just checking the uterus and the lining and see how many eggs you have, but to check for adenomyosis and polyps and fibroids and then hydrosalpinx. That's another thing that we can speak up with the ultrasound, because these can really influence the success rate of IVF. So if we see with the ultrasound that there's an abnormality of the uterus, they must think, maybe we must fix this first
Mm.
before we do another embryo transfer. Or even better, we should do this before we do the first IVF. We try to optimize the uterus before we start doing IVF. It's becoming also now more and more to tend to make sure that the uterus is healthy before we stick an embryo in that uterus. Huh?
Mm.
Makes sense, huh?
Yeah.
So, fibroids, benign growths of the uterus, can cause implantation failure, especially if they're growing on the inside of uterus. Polyps of uterus are very common. We see them every day, and they can reduce the chance of an embryo implanting. So a polyp is a benign growth of the lining of the uterus. We can take them out with a simple operation with a hysteroscopy. We've got now very effective surgical techniques. We've got what we call a hysteroscopic tissue removal system. So we go in with the machine under vision and we just cut it out.
That's
Very
what I
cool.
had all the time, actually. I had polyps all
Is
the
it?
time.
Yeah. Because so now we've got very cool machines to remove the polyps. So it's much better in the past. In the past, we took them out with graspers or with electricity. Now we've got these hysteroscopic tissue removal systems. And I mean, my colleague, Dr. Potau, just did one in theater. And it's a beautiful procedure because it goes quick and fast and efficient, and you can do it more effectively. So we can diagnose better now with the ultrasound, and we can treat it better because we've got better equipment. So we've got lots of advantages now. And then the other thing is adenomyosis. Huh? There's also a big one. And adenomyosis is a bit of a problem. So adenomyosis, I always called the dirty cousin of endometriosis. Huh? That's the cousin of endometriosis. So what's this? Endometriosis, it's a growth of endometrium outside uterus. Hmm? So the inside of uterus, we call that the lining. That's the endometrium. And when it's endometriosis, grows outside uterus. So adenomyosis is the same thing. The endometrium grows in the wrong place, but not outside uterus, but in the muscle of the uterus.
Mm.
Okay. So that's adenomyosis. It's actually endometriosis from the muscle of the uterus. And it can cause heavy periods and painful periods. Sometimes similar symptoms as endometriosis. But because it's a disease from the uterus, it can cause also implantation failure. And not endometriosis, huh?
Mm.
Because endometriosis is from outside uterus. If you do IVF on a woman with endometriosis and you put in a healthy embryo in the uterus, she's got the same chance as anybody else. But not with adenomyosis, because that's a disease from the uterus. So sometimes we have to do surgical treatment or medical treatment of the adenomyosis before we stick an embryo in that uterus. Surgical treatment is not always possible, but sometimes it is. And medical treatment means we give medication to suppress the adenomyosis, and then afterwards we do the embryo transfer.
Okay.
So for us, it's very important to make sure that we have a healthy uterus before we do an embryo transfer. So we need a healthy woman, we need a healthy uterus, and we need to try to get a healthy embryo. Huh? And the other thing that we do then for the healthy uterus is to do a hysteroscopy. A hysteroscopy means a look inside the uterus. A gastroscopy means a look inside the tummy. A colonoscopy means a look inside the colon. A bronchoscopy means we look in your lungs. Huh? Then we do a hysteroscopy, means we're going to look inside the uterus. That's a small procedure that we can do, and we can check if the inside of uterus is fine for implantation. Are there polyps or fibroids or things like that? But we can also take a sample of the lining to check if the lining is fine, if there's no chronic infection of the lining. Chronic endometritis, we call that. And that can happen and it's very treatable. So we check the lining to make sure it's ready for implantation and we can treat it if it's not possible, if it's not fine.
Okay.
So we check for the healthy lady, we check for the healthy uterus, and then we need a healthy embryo. That's the most difficult part, usually.
Okay. Thank you very much, Dr. Hayden. I really appreciate your time today. Thank you for answering our questions. I don't know if you got any closing words.
Yes, IVF is a statistical game. And if you do IVF, they say if you keep on doing the same thing over and over again and you expect a different result, that's the definition of stupidity. Huh? But for IVF, you must actually persist in stupidity. You must carry on doing the same thing. And if you do that in a proper way, huh, so that we address all the factors that I mentioned, then eventually nearly everybody will get pregnant if you got healthy embryos.
Okay. Thank you very much, Dr. Heylen. So, Doctor, if anyone wants to get hold of Dr. Heylen, he's at Cape Fertility. You can visit their website, www.capefertility.co.za. Everyone's details are on there in the contact forms. You can contact them that way or contact the office to make an appointment to see Dr. Heylen or any of the doctors at Cape Fertility. So they are on Instagram, Facebook, they're everywhere you can get hold of him. Thank you very much, Dr. Heylen. I really appreciate your time today. And I love having this chats with you because you explain everything so nicely that we can understand. Thank you.
I would like to continue this chat with you.
Okay, awesome. Thanks, Dr. Heylen.
You're
Bye.
most welcome. Thank you. Bye-bye.
Bye.